DHEA bottles sound weirdly confident. Youthful hormones, better energy, better sex, better muscle. But if DHEA naturally drops with age, isn't replacing it at least biologically reasonable? Or is that the exact moment where a normal aging marker gets turned into a sales pitch?
Reasonable is a question. Yes. DHEA is made mostly by the adrenal glands, then circulates largely as DHEA sulfate, or DHEA-S, which is more stable in blood. It can be converted in tissues into androgens and estrogens, but that conversion is local and regulated. Skin, fat, reproductive tissue, and brain-related pathways may not handle the same precursor the same way. So, taking DHEA is not like pouring one simple hormone into one simple tank. That also explains the trap in a lot of DHEA marketing. A supplement can raise DHEA-S, and that looks impressive on a lab report. But the relevant question is downstream. Did fatigue improve? Did sexual function improve? Did bone or muscle meaningfully change? And did risk stay low? In evidence terms, a move biomarker is the beginning of the story, not the ending. The most sobering aging evidence is that raising the hormone signal has not translated into a broad rejuvenation package. In a 2-year randomized trial in older adults with low DHEA-S, DHEA raised DHEA-S, but did not produce physiologically meaningful improvements in body composition, physical performance, insulin sensitivity, or quality of life. That matters because 2 years is long enough to ask about real function, not just a short laboratory bump.
So when people say DHEA helps women after menopause because it can feed estrogen and testosterone pathways, is that a different case? Or is it the same biomarker story with better branding? The mechanism sounds less random there, but the promise still feels broad.
For oral DHEA in postmenopausal women with normal adrenal function, the better reviews are not enthusiastic. The physiology is plausible, but placebo-controlled trials have not shown reliable benefits for sexual function, well-being, cognition, lipids, or carbohydrate metabolism. That doesn't mean every symptom is imaginary. It means DHEA is not a clean answer to a complex transition where sleep, medications, vascular health, relationship factors, and other hormones may all be involved.
The place I still hear DHEA discussed seriously is fertility, especially diminished ovarian reserve. Is that because the evidence is stronger, or because people facing IVF are willing to try anything with a plausible mechanism? And how do we keep hope from outrunning the data?
It's a more serious lane, but it should be clinician-led. A recent meta-analysis of oral nutritional supplements in diminished ovarian reserve found improvements in FSH, AMH, antral follicle count, retrieved oocytes, and clinical pregnancy rate. But it grouped vitamins coenzyme Q10 and DHEA, and subgroup analysis suggested coenzyme Q10 alone looks stronger than DHEA alone. Fertility treatment also has timing, stimulation protocols, and pregnancy boundaries. That's not a green light for self-directed hormone use during IVF. Post shows why baseline context matters so much. In many women with PCOS, the problem is not too little androgen signal. It is too much, plus insulin resistance and inflammation. Intermittent fasting studies in PCOS reported reductions in DHEA-S, free androgen index, insulin resistance, triglycerides, and CRP. Vitamin D trials also found improvements in insulin resistance and total testosterone, while DHEA-S was not clearly changed. So in that setting, pushing a precursor upward may be the opposite of the goal.
What about the longevity argument? If higher DHEA-S in men is associated with lower all-cause mortality, couldn't that mean DHEA is one of the aging levers we have been ignoring? Or could it simply mean healthier people tend to have healthier steroid profiles?
It is a clue, and an interesting one. A large systematic review of prospective cohorts found higher DHEA-S associated with lower all-cause mortality in men, but not women. The authors also emphasized sex-specific patterns and the need for studies on hormone modulation. In plain English, healthier adrenal and gonadal signaling may travel with better health, lower illness burden, or different body composition, but that is not the same as a pill extending life. Lifestyle can move steroid markers too, which makes DHEA labs tricky to interpret. A systematic review of ketogenic diets found oscillations in gonadal hormones, including DHEA, across small adult studies. Effects depended on sex, pose status, exercise, lean mass, and calories. That does not make keto a DHEA therapy. It shows endocrine systems respond to energy balance and training context. So if someone changes diet, training, sleep, and DHEA at once, the blood test becomes a noisy receipt.
If someone still wants to try it, what should they understand about the product itself? Is DHEA more like taking a vitamin, or more like buying an over-the-counter hormone experiment? I worry that the bottle format makes it feel gentler than the biology really is.
I would judge it like a targeted trial, not a vibe. Start with the reason: fertility protocol, documented adrenal issue, or a symptom plan supervised by a clinician. Define what would count as success before starting: a lab target, a symptom scale, or a treatment outcome. Also decide when to stop, because indefinite use turns a test into background exposure. If the only win is that DHEA-S rose while sleep, mood, libido, strength, or cycle goals did not, expectations should change.
Who should not casually experiment with DHEA? I am thinking about hormone-sensitive cancers, unexplained bleeding, acne or hair growth, mood swings, fertility treatment, pregnancy, liver or lipid concerns, and athletes who might fail a doping test. Are those hard stops, or at least reasons to bring a clinician in first?
That is the right list. My bottom line is DHEA is biologically real, but the broad anti-aging promise is much bigger than the clinical evidence. It may belong in narrow, supervised endocrine or fertility conversations, especially when the baseline problem and endpoint are clear. For a healthy adult chasing youth, muscle, libido, or mood, the best evidence says to be skeptical, measure outcomes honestly, watch for androgenic or mood effects, and not mistake a younger-looking lab number for a younger body.